Our first guest speaker today is Dr. Goodwin, discussing awareness of health disparities and how they impact health outcomes. The session will be moderated by PAS Lead Director Sonia Manocha. Please take it away.
There we go. Hello, can you guys hear me? All right, let's try and share my screen.
Good morning, Dr. Goodwin.
Good morning.
Just give me 1 second to have you set up here real quick. Okay, perfect. Okay, good morning, everyone. As Karina mentioned, my name is Sonia Manocha, and I am a PAS Lead Director. And it is truly an honor for me to be able to introduce our first speaker, Dr. Goodwin. Dr. Goodwin is a full-time faculty member to the South University PA program in Savannah. Her areas of teaching expertise are in ethics, anatomy and physiology, and public health. Additionally, she serves on the Interdepartmental Diversity and Inclusion Committee, representing the Savannah campus. The committee's mission includes incorporating diversity and inclusion, considerations and concepts within admissions, education, and other aspects of the student experience. She has a personal passion in expanding the healthcare's awareness of health disparities and how they impact health outcomes. Please join me in welcoming Dr. Goodwin.
Hello, good morning. All right, now, can you hear me okay? I just want to make sure I have all the buttons pushed appropriately. Yes, all right, thumbs up. Thank you so much. Well, first off, thank you so much for inviting me to come and speak on a Saturday morning. I really appreciate this. Whenever I heard first about your organization, I thought that is such an incredible mission, incredible organization that you guys, got together. It's interesting how everything kind of falls in place. So I will quit jabbering and let's get to what we have to talk about this morning. So that is my name. So we're going to talk a little bit more about me here. As Sonia mentioned, I'm an assistant professor at this PA program, and that's been occurring for about 6 years. I've taught graduate level, pre-nurses, associates, and even certificate level college courses for 11 years in total at different private, state universities and trade school type institutions. I am a doctor of chiropractic. And I am almost finished with my master's in public health, like almost. I have my final Tuesday, and then I have a practicum. So we're hoping spring of 2022. I'm the first of my family to graduate from college. I have an associate's degree. I've worked 2+ jobs while attending college myself. I hustled because I had to, and I just turned 40 years old. Oh, and I have chickens, keep bees, have a husband, and have 2 little kiddos. So there you go. Why do I bring this up? Am I filling up time with slides with information and leaning on social norms so that you accept it? It's a Saturday. There are plenty of other things to do. So I'm trying not to waste your time. Ugh. Do we have concerns about me talking about myself too much? Well, I hope not. Was the introduction not good enough? No, absolutely excellent. Sonia did a great job. I've got a point coming. So I'm actually tricking you into a lesson here. So we're going to get into neurology. Each of these pieces of both professional and personal trivia elicit some type of either subconscious or conscious belief about me. Biases can form as a result of how human brains have the tendency to categorize information. Our brains are so incredibly powerful, and there is so much massive amounts of information, of data that's coming in. Our brain's job is to really make sense of that information. Once something new has been categorized, the brain wants us to respond similarly to things placed in the same category. So what known or new groups do I fall into for you? So based upon that extra little information, each one of those bullet points, does any of that fall into a category that you might also be familiar with or experience? So shaping our categories. Our worldviews are shaped by so many different factors. This can include the generation that we are of, our cultures, our age, our exposures, and these can contribute towards the categories our brains neurologically establish. This input and organization can include both subconscious and conscious regulation. So I'm just going to stop right here for a second. So making this PowerPoint presentation, so I put all this information together, and I'm always pulling clip art from the internet. And so I was in PowerPoint and I'm like, all right, let's format this a little fancier. So I gave the opportunity for formatting and this picture pulled up and I thought, oh, great, at first glance. Great, excellent, let's use this. It looks like a picture of a young person holding a globe, and it gives kind of that image that I was going for with regards to how worldviews can shape how we see the world. Well, take a closer look at this stock image from PowerPoint. What we see here, what's highlighted in the center of the globe, is this view that we also have, which is typically North America is located in the center of the globe. So I could go on and on and on and on just about this image alone, and how at first glance we might recognize it, become familiar with this type of imaging. It gives that sort of story that we're trying to relay, but at closer reflection, when we consciously think about it, there is some messaging with that as well, that oftentimes if we don't, point a light at this, we may not realize that we're being influenced by. So shaping our categories takes conscious efforts of challenging these categories that we've established and that we continue to build upon. So that brings me to ethics for just a quick little session here, okay? So this is the opportunity where we can challenge our processing, challenge our neurology, challenge these categories that we establish for ourselves. So ethics is a branch of knowledge that deals with moral principles. So those of you PA students, just bear with me for a second here. We can talk about blood pressure and pulse oximeters in a little bit. So some common terms in ethics and things that I think are important to consider and be aware of and bring to our consciousness. Ethical humility is the awareness of one's own limits in ethical insight. Ethical courage is the willingness to fairly assess ideas, beliefs, and differing viewpoints. Ethical empathy is the willingness to attempt to understand the opinions of others. Ethical fair-mindedness is to hold your own beliefs to the same standards of proof as opinions of others. So this may help us navigate the world with people that have differences. So back on, the train of bias, discrimination, and disparities. Bias is a prejudice for or against something. It can have a positive or negative consequence and be conscious or unconscious. Bias can occur relating to categories of age, sex, gender, physical abilities, religion, sexual orientation, gender identity, race, ethnicity, weight, etc., etc. Discrimination is the unfair treatment of people based upon their characteristics, or as we mentioned with the discussion in the intro, categories neurologically that we tend to put people and things within. Disparities, now these are preventable, that's kind of the key word, I think, differences in the burden of opportunities to achieve optimal life as experienced by socially disadvantaged populations. We know that bias can lead to discrimination and disparities, which here's the part that you all will see when you get out in practice, which can lead to differences in outcomes. And many of these that you will experience are health outcomes. So health disparities, kind of another formal definition, are inequities in the quality of health, healthcare, and health outcomes experienced by groups based upon social, racial, ethnic, economic, and environmental characteristics. So health disparities and health equity are things that we should examine in coupling. So as we mentioned, the definition of health disparities, again, highlighting that these are things that can be preventable. So there are differences in the experience of these, people or groups of people. Health equity is when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this because of social position or any other factor. Okay, so this is the opportunity for everyone to have that same, experience or same resources. So you're probably familiar, obviously, with what, health disparities are and, the differences between different groups of people that we do see, in medicine. So health disparities are disproportionate numbers of conditions and deaths compared to the general population. So I know I have lots of definitions in here, but I want to try and make it, really kind of simple. So for example, in this illustration, African Americans make up 13% of the US population, but represent almost half of new HIV cases. So there's something going on there, with that population. Why are we seeing more disease in some population group? And so this brings to, I've used this illustration whenever I teach ethics. I just love this picture. I love creating a visual to help people understand the differences between these words, between equality, equity, and then, hopefully justice. So in reality, there are groups of people, there are individuals that have more opportunity, okay, while other people get less than what they need. And so the result here in this image, we have, presumably, I think it's baseball game going on, and we have a fence. So we have 3 different people attempting to peek over that fence and watch the baseball game, okay? So obviously we see one person is, very well suited to see that game. So they have like 18 boxes that they can stand on. Another individual has 1 box and they're really like reaching hard to look over that fence and see the game. And then we have a third person who not only doesn't have a box, they are standing in a hole, right? So there is no way that that person is going to be able to see the game. So I love this visual because this, kind of helps me realize what life and what life experiences are like for different people. Equality is the assumption that everyone benefits from the same support. So when we hear that word equality, that tends to give us that feeling, that vibe, that it's a good word. And I'm not saying it's a bad word, but with equality, we're giving everyone the exact same thing, right? The same amount of the same thing. I will prescribe some level of judgment here. It is a step better, than reality. Whereas with equity is a term that refers to giving everyone what they need in order to see the baseball game, in order to, realize health. And then justice, this is like, the hope, the goal for the future is that everyone can see the game and we remove the fence, right? I mean, it's sort of like in medicine, when I talk with my students, one of the things that I always go into is when you have a patient presenting with a condition, figure out what is causing the problem. And if you can fix that, right, then you will be the hero. Then you will be doing the most good, okay, as opposed to just treating the symptoms. So here with justice, it's kind of similar in regards to public health and ethics. So if we can remove the barrier, then we are providing, the most optimal future, if you will. All right. So as you know, I'm working on my public health degree here. So a lot of this references public health, and a lot of you on the board, I was kind of researching you the other day, have education on your own right in public health. And so I hope this is still helpful for you guys, but that's really great for PAs to have some public health knowledge, with their education and experience as well, because public health deals with health experiences in populations. So what you will be doing, I'm speaking to you collectively, I assume I'm putting you in the category, in the box of PA students. So your experience, what you will be doing is going out and treating individuals by and large, right? Yes, you'll be treating families. And hopefully you will amass a great population within the community as well. But public health, their focus is on the community. So their focus is looking at, health disparities and differences between populations. And so I challenge my PA students and PAs, in general, to consider opportunities where you see patterns occurring within populations. That's not our inherent training as individual providers in healthcare, but I'm just asking us to think and watch that. So anyway, back to the slide. So in public health, we have these various essential public health services, and they do a really great job of making images and marketing and so on and so forth. Very organized. But if you notice, what is at the center of the 10 essential public health services? It's equity. So it is, in order to provide the appropriate number of boxes for everyone to see over the fence, we have to first see how many boxes these individuals might need, right? And so that is baked in to the recipe of public health, is actually looking at these communities, at these populations, and assessing what their needs might be, so that the goal can be to provide the appropriate resources for those folks that might need it. Okay, so in order to have a healthy population, everyone should have access. So health is the state of complete physical, mental, and social well-being, and not merely the absence of disease. I love this definition from the World Health Organization. It's kind of funny, we take a lot of these very simple medical words and you try and find the definition, and there's like 16,000 different definitions for a very common medical word. Health is one of those. So if you Google search the definition of health, you can have all of these official organizations come up with their own identifiable definition. But this is one that I really like. I gravitate towards this one. And the reason being is because it's considering more than just physical health and the absence of illness, right? And it's going to come together. So how can we improve health as we defined it and reduce health disparities? So the first step, I think, is to know your audience. And oftentimes this is what we're missing, right? So we can gather information, absorb accurate information, distribute appropriate information. And I'm going to stop right here on this first bullet point. You guys are all learning so much information in your PA education, but you're absolutely right with that introduction that there are so many gaps in knowledge with regards to differences between sexes, even differences between cultures, differences between races, even differences between regions within this country, okay? So that's a known, and you guys are already, it sounds like, shining a light on that aspect so that we can move forward with medical education and provide a little bit more of this first bullet point. Updated, accurate information about what is really out there. Okay, so that means we need to ask those questions and share that information. Asking for input from the community members. So if there's something going on, reaching out and actually talking to the people that we think are being impacted by something. And this lends itself naturally and inherently to the ability to provide or learn about cultural considerations. Because if we have, like you mentioned, Ms. Karina, early on, we have this sort of standard textbook sort of, this is the situation, this is how we handle it. And it's very, recipe cookie cutter. That doesn't always apply to every culture. There might be something going on with a belief system or just a simple practice where that may not work for them. Okay, so we have to be able to engage with folks that might be different than us. And then we include population representatives in planning sessions. So if we have a project going on, let's say, you're out in practice and let's say you have a goal in your local community patient population that you want to, reduce hypertension. Let's say that's a goal you have in your practice. So you can include those folks that are within your community and within the communities that you're seeing a lot of hypertension in the planning session. So when you're establishing kind of the things you might want to do in your office or at the park, it fits with what they might, be comfortable with. All right. Considering social determinants of health as they relate to your patient's presentations, partnering with local public health departments when disease prevalence increases. So whenever I talk about public health with my students, this is another thing. Again, as PAs, when you step out into the universe and you provide your wonderful gifts to your communities, you are kind of like the first line when it comes to public health and comes to identifying that there might be, some of these social determinants of health going on. So if you notice in certain populations that you're starting to see a rise in this condition, you can partner with a public health department and say, hey, I have a large group in my practice where I'm seeing hypertension, and 10 years ago, we didn't really see a lot of that. There might be something going on. That's what can trigger public health to do investigations, to take a look, to start investigating with that population and see if there's some access issue going on, perhaps. We can challenge beliefs and categories about someone or something and use and apply that ethical humility ourselves. All right, so social determinants of health. Ooh, I'm running out of time. Per usual, I'm a talker. All right, here we go. Really quickly, sorry about that. Social determinants of health. So these are some things that we might not think about that can have direct and real impact on our patient's health, okay? And these are not directly health things. So it might not be, whether or not we can eat organic food. It could be very simply, what's the literacy rate in this community? Does this community have access to public transportation? Easy access. Is public transportation affordable? Okay. What's the stress level? Is there violence in their neighborhood? I'm just pulling a couple out as examples, because these things do have real impacts in health. All right. So I'll go through this one quickly. I wanted to kind of give you an illustration, for example, to apply some of these social determinants of health. So let's say we have
Goodwin. I'm so sorry to interrupt you. You have plenty of time.
Oh,
you're okay. 30 minutes. You're doing great.
All right. I looked at my watch wrong. I'm like, oh, all right. Thank you, Sonia. All right. So I'll slow down just a smidge. Okay. So in this example, so we have an immigrant Vietnamese population living within a community. Where are they living? They're living, let's say, in an unincorporated rural area. They don't have city water, and they don't have public transportation. And many of them may not have driver's license. They may not all own personal vehicles. So how could that impact health? So if you look at those things at first glance, you may not see health impacts, staring at you. But I'm here to tell you that those things can directly and indirectly relate to those patients' health. So we have limited access to city resources. This could, I could spend all day talking about this. So this could relate to the ability to receive information about employment. So they may not be able to, let's say, get into town to see those message boards, to interact with these businesses, to see if there are jobs available or open. That can directly relate to health insurance. So see how just access to getting into town can translate into the inability to have health insurance. And then how will that reflect on sort of the motivation or the ability to get in to see a doctor for a checkup or a PA? They may have issues or difficulty with clean water, or maybe even, again, they're not getting into town. They may not have the information to research or find connections with people that can help them address their water where they live. If they're farming, they may have limited access to sell or barter because, again, that transportation issue. So even if they're living in an unincorporated rural area and they're farming something or some things, because transportation is a barrier, they may not be able to make an income from that which they are farming, or trade or barter with another farmer. And so this can also translate, I was trying to be a little creative here, to limited access to diversity in their diet. So they may be limited to what they eat based upon what they grow on their property. And they may have limited ability to travel to healthcare providers. So not only the health insurance and the financial component of paying for healthcare, just by not having, adequate transportation, they may not have a means to get to appointments. So we can see how that can trickle down and impact, a host of health outcomes, including increases in chronic conditions and the more severe cases of even acute conditions. All right, so bringing it all together. So you as PA students are going to learn quite a lot of didactic, what I call hard sciences. So you guys are going to learn a lot of, textbook information about, how things work. And, I'm going to add this little caveat in a majority of the population. So this is definitely an area that we can improve on. But this includes, physical assessment, geriatrics, pharmacology, A&P, patho, ortho, et cetera, et cetera. So these types of things guide us on what to practice, okay? And these things are not perfect by any means. As we point out, we need to do a better job of gathering accurate information from different populations with regards to objectively treating these people, okay? In addition to all of that work that we have ahead of us, we have conceptual education. So this is like the epidemiological modeling. So actually looking at numbers, what groups of people tend to have certain conditions, applying public health concepts, applied psychology, jurisprudence, which is a fancy word for law, ethics, marketing, philosophy. These types of concepts of curriculum guide us on how to practice. So in PA education, we have some of this embedded within the curriculum. So what I'm trying to say here is that although lots of you as PA students will hopefully very likely, graduate the pants and become excellent, technical and objective providers, I just challenge you to consider some of these other conceptual pieces of education so that even with the base of knowledge that we have now, imperfect as it may be, that we can apply that information more appropriately to our diverse patient profile. So a large portion of how we practice healthcare includes consideration of inequities of resources, access to resources, cultural differences, and again, those health disparities, okay? So how do we make an impact on the greater healthcare profession? So if we could, wave a magic wand, we keep asking questions, observing, sharing knowledge, and creativity, pouring our hearts and our time into the good fight. So I encourage you guys, keep doing what you're doing, how you're doing it. Let's increase that objective, medical, scientific base of knowledge with our diverse patient and human profile so that we have better, accurate, updated information to treat people better. And also consider those other conceptual pieces of curriculum so that we can apply that updated information much better and hopefully have better health for everyone. So with that, thank you for inviting me. I hope you guys got something out of that and enjoy your Saturday.
I know that the chat was a little active, so I don't know if there were any questions or anything.
Thank you, Taylor.
Dr. Goodwin?
Yes.
Hi, I'd like to ask you a question.
Okay.
What is a bias that you see a lot of people in healthcare doing that you wish you knew as a student so that you don't even get into that type of habit? Just something so common, people don't realize this is an implicit bias that I'm putting onto a patient.
Yes. So I would probably say personal opinion from my life experiences is that I have seen, myself included, full disclosure, I overshare even my weaknesses, that providers can assume that when patients aren't following through with treatment plans, or they present in high numbers within a population of a condition, that it's their fault, that they are not doing something, that they might be, lazy or disinterested, okay? When in fact, digging into this public health education, a lot of the inability, the non-compliance may come from, those social determinants of health. It may actually be, a frustration that although in the treatment plan, we're asking them to do something 3 days a week, go here, I need you to do this on Monday, this on Wednesday, this on Friday. So, and in our minds as providers, there's a reason medically we want that to happen. We want it spaced out. We want time in between. We maybe want, some medication to dissipate before they do the next thing. So medically, objectively, there's a reason behind why we want it that way. And so oftentimes we kind of have a gap in our understanding as to why compliance is so low in certain populations. And, through this, digging into this information, it really set off a light bulb for me that perhaps transportation is an issue, and it's been an issue for a long time. And so there, it's just like, well, here's another thing that perhaps I can't do as well. And it may highlight those disparities, quite frankly. So.
Thank you. Do you have any resources you like to use that show questions that you should be asking patients to really get into those social determinants?
That is a great question. I do not, because in my education, I learned to be a provider first, and then just recently started noticing differences in population and having this passion to improve the conditions for people, just kind of that innocent drive myself. And that allowed me to fold into and kind of step into public health. And that's like, oh, this is it. This is what I was trying to learn. And so that's actually a really great question, to formalize or kind of standardize some set of questions for providers so that they could get at, the potential consideration of if their outcomes could be related to some of these social determinants of health. So I know is the answer. I don't have that, but that would be great to have, honestly. Because one of my goals is to help bridge public health with medicine as together, because there's so much opportunity for overlap. In learning public health, it's like we deal with communities, but then we see how individuals are impacted. And then in medicine, we deal with individuals, and we're starting to see how communities are actually involved. And so bringing these two together, it's like the perfect party, right? Because a lot of good change, I think, could happen with that occurring. So yeah, that would be, a really great resource. One thing that I do say with my students, I really encourage, if you start seeing things occurring, a common pattern within a population of your patients, to get in touch with your local public health department and let them know, because like I said, those folks have the resources. They could perhaps get grants. They may know some base knowledge as to what might be going on. Maybe there is unsafe drinking water that they've located in that zip code, that you were kind of that extra prong to really fuel action, right? To get that fixed. So that is definitely one thing, even without the questions. If you're just observing similarities within a community, let the public health department, know, and they can hopefully facilitate that community investigation and research. All right, I'm looking at chats.
So Dr. Goodwin, thank you for speaking with us. This has been amazing. In the chat, I mentioned that I agree that we learned so much during didactic year, but it's like just regular medicine, and it's hard to apply that to a different or a diverse population of people. And so while I was on my clinical rotations, I learned so much from talking to patients and just spending that extra time. And as a student, I'm able to do that, or I was able to do that. So how do you think that you can, that like in PA education, that gap can be bridged where you do get some of that individualized information that can help you for future patients, but not slow the process down so that we can't get through school?
That is another great question, because PA education already is so jammed packed with curriculum. So that is a great question. You know, I'll tell you, with my work in, you know, the diversity interdepartmental or intercampus, you know, diversity committee, that's something we are constantly talking about. Like, and one thing that we're doing right now from a faculty standpoint is we're analyzing courses that have occurred and seeking out opportunities where we can infuse considerations of, you know, diverse populations or cases that are not just, you know, a postmenopausal white female. So that's something that, you know, I am, you know, that person like, hey, let's change this case up, you know, let's make it, you know, a transgender male who, you know, is 35 years old, et cetera, you know, so we can still, the diagnosis may end up still being a cardiovascular case, but let's change up some of the patient profile. And that can allow for opportunities for the students to kind of stumble and struggle with how to navigate, you know, interaction with that patient with regards to, you know, taking a history, and see how we kind of open our minds to consider other factors that may play into this. I think that can be helpful. And also, you know, this is not up to you, but having a little bit more public health curriculum infused, you know, some of these concepts, I guess, at least I should say. And then adding, I love that idea about adding questions to consider, asking our patients to see if, you know, some of those social determinants might be impacting, you know, health disparities. I think that's a great idea. Yeah. You can ask for those things as students. Great. I mean, that is a good point, that when you get into your clinical year, you're going to see, you know, patients of all different kinds. I mean, we send our students to rotations all across our region, all across our state, different states, different types of practices. You know, we have one practice that is one of our women's health rotation, and it is I believe it's a nonprofit. I don't think that they directly take funding, but they serve Muslim women. And so, you know, that's a really unique opportunity, you know, to be on that rotation. And so that's a great question. How do we prepare the students to, you know, interact with those type of diverse patient profiles? Yeah. Yes. And so, Ms. Karina, I saw your comment there. I remember asking a clinical preceptor about having a transgender male patient who is taking hormone therapy and presents with osteoporosis. How does that affect your treatment plan? They had no idea, and we couldn't find much information online either. Exactly. Exactly. There may not be, you know, as you know, presented in the beginning, our textbook information is, you know, essentially built upon white males. That's the research in, you know, in medicine. I don't want to go too far deep into the history of medicine and all the biases. The term hysterectomy, I'll just leave that there. You guys can look that up. But there's, you know, that is a lot of where, you know, we came from, where we studied, and what our base of knowledge is in. So any differences, yeah, we've got to do better, you know, and we've got to adapt with the knowledge we have. and understand and realize and actually see and shine a light on the knowledge gaps that we still have, and, you know, try and get out there and get more research and talk to patients, you know, as well. So engage them instead of just giving them the same cookie cutter recipe for treatment. You know, talk to them, say, hey, how are you feeling with this, that sort of thing. So bring the humanity back in, even if we do have knowledge gaps. I think that is a huge key, is bringing that humanity back to medicine.
That was amazing. Thank you, Dr. Goodwin. Does anyone else have any questions? That was such an amazing presentation. Thank you again for taking your time out on a Saturday to come talk to us. We will now have a short break, everyone, till 11:10 if you guys want to take a break. But before I do head out, I did just want to introduce myself real quick again. I actually go to South University, so Dr. Goodwin was one of my professors, and truly appreciate her from the bottom of my heart. I just recently joined PAS Lead, and I was so excited for to participate in this conference, and I truly encourage everyone to look into the organization. I know we have a couple other director positions open. It's an amazing organization. I love everyone that's included, and everyone shares so many amazing resources. And I think that's my favorite part about PAS Lead, is that if I'm ever like in need of something or need help, or like struggling with a diversity aspect, because I am diversity chair of South University, and sometimes it's hard just being someone that is kind of in charge of pushing my class in that direction. I can use the resources that PAS Lead provides, and the community is beautiful. So I am really thankful. And so, yeah, please follow us on Instagram, Facebook, Twitter. But yeah, that's really all I have to say. Thank you everyone for joining us. And yeah, please, you can stay on. We will put the schedule back up. And I know a couple of other directors will be able to introduce themselves in the little time that we have. Thank you guys again. And thank you, Dr. Goodwin.
Thank you.